Welcome to the deep dive. Today, we're really getting into something fundamental, the body's blood cell factory, the hematopoietic system. We're using chapter 21 of Porth's Pathophysiology as our guide. Our goal here is pretty straightforward. Take this complex topic, how blood is made, what it's made of, how it's all controlled, and, well, make it stick, make it clear.
Absolutely. And blood itself, it's fascinating. It's not just liquid, it's technically a specialized connective tissue. It makes up about, 7 to 8% of your total body weight. So maybe 5 to 6 liters in an average adult. It's just the perfect transport system.
The perfect vehicle. And that vehicle has basically three main groups of components. You've got the fluid part, that's the plasma, and then you have the actual cells or formed elements.
Right.
Erythrocytes, red blood cells, leukocytes, white blood cells, and thrombocytes, which we know as platelets.
Right. So let's imagine taking a blood sample and spinning it down in a centrifuge. You actually see these components separate out, right, like layers in a jar. At the very bottom, you get this dense reddish layer. That's the erythrocytes, the RBCs. Takes up maybe 42 to 47% of the volume.
Yeah, a big chunk. And sitting right on top of that red layer, there's this thin kind of whitish or grayish layer. It's tiny, maybe 1%. That's called the buffy coat. And that's where you find the leukocytes, the white blood cells, and the platelets packed together.
Okay, and then the rest, the top layer, which is actually the biggest part, about 55%. That's the plasma. It looks kind of translucent, maybe yellowish. Now, you mentioned plasma is mostly water, like 90%. But that other 10% must be doing something really important.
Oh, absolutely critical. That remaining bit is packed with stuff. About 6.5 to 8% is proteins, and then you've got nutrients, hormones, electrolytes, waste products, all sorts of things. Plasma's job list is long. Transport, obviously, but also managing electrolyte and acid-base balance, even absorbing and distributing body heat. But yeah, the proteins are the real stars.
The plasma proteins, these are what make blood different from just, the regular fluid bathing our tissues. Tell us about the main ones.
Right. The big one, the heavyweight champion, is albumin. It makes up more than half, about 54% of all plasma protein. Albumin's molecule is just too large to easily sneak out of the blood vessels. This makes it the key player in maintaining what we call plasma osmotic pressure.
Osmotic pressure, like it hold water in.
Exactly. Think of it like a sponge or maybe an osmotic magnet, keeping water inside the blood vessels. That's crucial for maintaining your blood volume and pressure. It also acts as a carrier for some things, like certain drugs or hormones, and helps buffer the blood pH.
Okay, so albumin's about volume and carrying stuff. What about the globulins? They're the next biggest group, right? About 38%?
Yep, the globulins are a more diverse bunch. We group them into alpha, beta, and gamma. Alpha and beta globulins are mostly transporters, too. They carry things like bilirubin, steroids, iron, copper, specialized delivery trucks, basically.
And gamma.
Gamma globulins. Those are your antibodies. They're a huge part of the immune system, the soldiers fighting off infections. Really vital.
Got it. And the last main protein type, fibrinogen. That one sounds like it's involved in clotting.
Precisely. Fibrinogen makes up about 7%. It's a soluble protein just floating around, but when clotting is triggered, it gets converted into fibrin. Fibrin is insoluble, and it polymerizes, it links together to form this sticky mesh that traps blood cells and forms the structural backbone of a blood clot.
So fibrinogen is in plasma, but fibrin forms the clot.
Right. And that leads to a definition we often use in the lab: serum. If you let blood clot and then remove the clot and all the clotting factors, including the used-up fibrinogen, the fluid left over is serum. So serum is basically plasma minus the clotting components.
Okay, we got the liquid highway, the plasma. Now let's talk about the traffic, the formed elements. You mentioned earlier, it's interesting that only leukocytes, the white blood cells, are really considered true cells in the traditional sense.
That's right, because mature erythrocytes, red blood cells, they kick out their nucleus and organelles as they develop. They're basically just flexible bags packed with hemoglobin. And thrombocytes, or platelets, aren't even cells. They're just fragments that break off from larger cells. So yeah, only the WBCs have the full set of cellular machinery.
And all three types originate in the bone marrow. They don't last forever, so the marrow has to constantly churn them out.
Let's start with the most common ones. Erythrocytes, the RBCs. They are incredibly numerous, tiny little things, just 6 to 8 micrometers across. And they have that unique shape, like a flattened disc, concave on both sides, biconcave. This shape gives them a huge surface area for gas exchange, and importantly, it makes them super flexible.
Flexible enough to squeeze through tiny capillaries that are even narrower than they are.
Exactly. They can deform, almost fold over on themselves to get through those tight spots without rupturing. It's quite an engineering feat.
And their main job, their whole purpose really, is carrying oxygen. That's thanks to the hemoglobin molecule inside them, which, incidentally, is what gives blood its red color. They also play a role in carrying carbon dioxide back to the lungs and helping with acid-base balance.
Their lifespan is about 120 days, give or take. After that, they get old, less flexible, and about 90% are removed by phagocytic cells, cleanup cells, mainly in the spleen, but also the liver and bone marrow. The components, like iron, get recycled.
Okay, moving on to the defenders. The leukocytes, or WBCs, these are the core of our immune and defense systems.
Absolutely. They fight infections, respond to inflammation, help heal wounds, and some even target and destroy cancer cells. They're crucial. We generally split them into two main categories based on how they look under a microscope, particularly their granules and nucleus shape. You have the granulocytes and the agranulocytes.
Granulocytes have visible granules in their cytoplasm, right?
Yes, specific granules that stain characteristically. And they tend to have multi-lobed nuclei. The agranulocytes lack those obvious specific granules. They might have some fine ones and typically have a single non-lobed nucleus.
Let's tackle the granulocytes first. These are all phagocytes, meaning they can engulf things.
Primarily, yes. The big players here are the neutrophils. They're the most abundant WBC, making up 55 to 65%. Think of them as the first responders, the rapid reaction force, especially against bacteria and fungi. They're expert phagocytes.
And they have that distinctive nucleus, don't they? That's why they get that other name.
PMNs, yeah. Polymorphonuclear leukocytes, because their nucleus usually has 3 to 5 distinct lobes, making it look segmented or many-shaped. Their lifespan is short, though, maybe 5 hours in circulation, up to 5 days in the tissues once activated.
Okay, now this is where we hit a really key clinical point from the chapter, the idea of immature neutrophils, the banned cells.
Right. This is super important clinically. Normally, you only have mature, segmented neutrophils circulating. But if you get a severe, sudden bacterial infection, the classic example is something like acute appendicitis or sepsis, the demand for neutrophils skyrockets. The bone marrow goes into overdrive and starts pushing out slightly immature neutrophils before they're fully segmented. These have a nucleus shaped like a band or a horseshoe.
So it's seeing a lot of these banned cells in a blood count.
It's called a shift to the left, and it tells you the body's under significant stress fighting a major bacterial battle. It's a red flag for clinicians indicating an acute, possibly severe infection. That case study of the 14-year-old boy with suspected appendicitis really highlights this.
Very clear.
Okay.
Okay, who are the other granulocytes?
Next up are the eosinophils. Much less common, maybe 1 to 3%. They typically have a 2-lobed nucleus, and their granules stain bright red with eosin dye. Their specialty is dealing with allergic reactions and, maybe more famously, parasitic infections, especially worms. They're also involved in chronic immune responses, like in asthma.
And they have an interesting role in controlling inflammation, too.
Yes, they release enzymes like histaminase, which actually breaks down histamine, so they help modulate or dampen down the severity of allergic inflammatory reactions. They're not just pro-inflammatory.
Okay. And the last and least common granulocyte?
The basophils, less than 0.5% usually. Their granules stain dark blue or purple and are packed with powerful chemicals, heparin, which is an anticoagulant, and histamine, a major vasodilator involved in inflammation. They also release other inflammatory mediators. They play a big role in allergic and hypersensitivity reactions, acting very much like mast cells, which are found in the tissues.
Right, that covers the granulocytes. Now, for the agranulocytes, also called mononuclear leukocytes, first are the lymphocytes.
Lymphocytes are the core functional units of the adaptive immune system. They make up about 20 to 30% of WBCs. They circulate between the blood and the lymphatic tissues. They're quite mobile. There are 3 main types you need to know. B lymphocytes, which are responsible for humoral immunity, meaning they mature into plasma cells that produce antibodies. Then you have T lymphocytes, which handle cell-mediated immunity. This includes helper T cells that orchestrate the immune response, and cytotoxic T cells that directly kill infected or cancerous cells. And finally, natural killer NK cells. These are part of the innate immune system. They can recognize and kill certain tumor cells or virus-infected cells without prior sensitization.
So lymphocytes are really about specific targeted immunity. What about the other granulocyte, the monocytes?
Monocytes are the largest type of WBC, about 3 to 8%. They circulate in the blood for only a few days. Their real job starts when they migrate out into the tissues. Once they leave the bloodstream and enter tissues, they transform into macrophages. Macrophage literally means big eater.
And they live up to the name.
Oh, yes. They are incredibly powerful phagocytes, much more capable than neutrophils. They can engulf larger particles, cellular debris, old cells, and pathogens. They also play a critical role in presenting antigens to T lymphocytes, essentially telling the adaptive immune system what to attack. They're vital for cleanup and for initiating specific immune responses.
And they get different names depending on where they set up shop, right?
Exactly. In loose connective tissue, they're called histiocytes. In the brain, microglial cells. In the liver, Kupffer cells. Same cell lineage, different location, slightly specialized roles.
And they're involved in a specific type of inflammation mentioned in the text.
Yes, granulomatous inflammation. This happens when macrophages encounter something they can't easily digest, like the bacteria that causes tuberculosis or certain fungi, or foreign materials like sutures. Instead of just dying, the macrophages surround the offending material, fuse together sometimes, and form a wall or capsule around it. This structure is called a granuloma, like the tubercle you see in TB. It's the body's attempt to contain something indestructible.
Fascinating way to wall off a problem. Okay, last but not least in our formed elements tour, thrombocytes or platelets.
Platelets, not true cells, remember, just fragments. They bud off from massive cells in the bone marrow called megakaryocytes. They circulate for about 10 days. They have no nucleus, so they can't divide or make proteins. Their main job is hemostasis, stopping bleeding.
How do they do that?
Two main ways. First, when a blood vessel is injured, they quickly stick to the damaged site and clump together, forming a temporary platelet plug. This is the initial rapid seal. Second, they release a whole cocktail of chemical mediators that are essential for initiating and propagating the blood coagulation cascade, that process involving fibrinogen turning into the fibrin mesh we talked about earlier. They basically kickstart the process of forming a stable clot.
All right, we've got all the different blood cells and the plasma they travel in. Now, let's look at the factory itself. Where do all these cells actually come from? The process is called hematopoiesis, right? Blood making.
Exactly, hematopoiesis. In the very early embryo, it starts in the yolk sac. Then, during fetal development, the liver and spleen become the main sites. But shortly before birth and then throughout postnatal life, the primary site shifts almost entirely to the bone marrow.
So bone marrow is the main factory for adults.
Yes, specifically the red bone marrow. This is called medullary hematopoiesis because it's happening inside the marrow cavity of bones. In adults, red marrow is mostly found in the flat bones, like the pelvis, sternum, ribs, vertebrae, and the ends of long bones. Where the marrow isn't actively making blood cells, it gets filled with fat cells and looks yellow. That's yellow marrow.
Can yellow marrow turn back into red marrow?
It can, yes. If the body has a greatly increased need for blood cells, say, after severe bleeding or with certain types of anemia, the yellow marrow can be replaced by active red marrow. It's called resubstitution. The system has some flexibility.
And what about that earlier mention of the liver and spleen making blood? Can that happen after birth?
It can, but it's usually only under pathological conditions. If the bone marrow fails significantly, the liver and spleen can reactivate their blood-making potential. This is called extramedullary hematopoiesis, and it's generally a sign of disease like severe anemias or bone marrow cancers.
Okay, the location makes sense. Now, the cells themselves, how does one type of cell in the marrow give rise to all these different blood cells? It starts with stem cells, doesn't it?
It all begins with the pluripotent stem cells. These are remarkable cells found in the bone marrow. Pluripotent means they have the potential to develop into any type of blood cell. Crucially, they also have the capacity for self-renewal. They can divide to make more stem cells, maintaining the pool throughout life. They are the ultimate source.
So the pluripotent cells are the reserve. What happens next?
These pluripotent stem cells then differentiate, meaning they commit to becoming a specific lineage. They turn into colony-forming units, or CFUs. These CFUs are often described as unipotential or multipotential progenitors. They're committed to producing, say, just erythrocytes, CFUE, or maybe granulocytes and monocytes, CFUGM. These still have some self-renewal ability, but it's limited compared to the pluripotent stem cells.
And from the CFUs?
The CFUs then divide and mature into the recognizable precursor cells for each cell type, like erythroblasts for RBCs, myeloblasts for granulocytes, and so on. These precursor cells lose the ability to self-renew. Their job is just to proliferate, multiply, and mature into the final functional blood cells that get released into circulation.
It sounds like an incredibly complex and finely tuned production line. How is it all regulated? How does the body know when it needs more red cells or more neutrophils?
It's regulated by a fascinating system of chemical messengers, mostly hormone-like growth factors called cytokines. These are generally short-lived mediators that stimulate the proliferation, differentiation, and activation of the various blood cells.
We often hear them called colony-stimulating factors, or CSFs.
That's right. Many of these key cytokines are CSFs. For example, erythropoietin, or EPO, is the main stimulus for red blood cell production. It's mostly produced by the kidneys in response to low oxygen levels.
EPO. That's the one sometimes misused in sports doping.
Unfortunately, yes, because synthetic EPO can boost red cell count and oxygen carrying capacity. But naturally, it's essential for responding to anemia or high altitude.
Are there specific factors for other cell lines, too?
Absolutely. Granulocyte colony stimulating factor, GCSF, primarily pushes the production of neutrophils. Granulocyte macrophage CSF, GM-CSF, is a bit broader, stimulating progenitors for granulocytes, monocytes, and even impacting red cell and platelet precursors. And thrombopoietin, TPO, is the main driver for platelet production, stimulating the differentiation and maturation of megakaryocytes.
And this knowledge isn't just academic, is it? We use these factors clinically.
Hugely important clinically. We now have recombinant manufactured versions of EPO, TPO, GCSF, and GM-CSF. We use them routinely to treat low blood counts caused by various conditions, for instance, to help patients recover their white blood cells after chemotherapy, to treat certain types of anemia, especially associated with kidney disease for EPO, or to boost platelet counts. It's a major application of understanding this hematopoietic regulation.
Okay, so we have this amazing regulated system. But what happens when that regulation fails, or the stem cells themselves have problems? How does this link to actual diseases we see?
Well, things can go wrong in several ways. If the hematopoietic stem cells fail to produce enough cells, you get underproliferation. The most severe form is aplastic anemia. This is essentially a failure of the pluripotent stem cells. Since they're the source of all blood cells, their failure leads to pancytopenia, a shortage of everything. Red cells, anemia, white cells, leukopenia or granulocytopenia, and platelets, thrombocytopenia. It's a very serious condition.
And the opposite can happen too, overproduction.
Yes, unregulated overproduction leads to a group of conditions called myeloproliferative diseases, or neoplasms. This includes things like polycythemia vera, where there's a massive overproduction of red blood cells, making the blood too thick, or essential thrombocytosis with way too many platelets, increasing clotting risks. And of course, the various types of leukemia, which are essentially cancers, characterized by the uncontrolled proliferation of abnormal white blood cells, often crowding out the normal marrow function.
And for some of these severe marrow failure or malignant conditions, the treatment involves replacing the whole factory.
That's right. Hematopoietic stem cell transplantation, often called bone marrow transplant, those stem cells can also be harvested from peripheral blood or umbilical cord blood, is a major treatment. It can be used for aplastic anemia, certain immunodeficiencies, leukemias, lymphomas, and other cancers, basically to replace the patient's diseased or failed marrow with healthy stem cells from a donor, allogeneic, or sometimes using the patient's own cells collected earlier, autologous.
So how do we actually diagnose these problems? What tests do doctors use to look at the blood and marrow?
The absolute cornerstone is the complete blood count, the CBC. This is a routine blood test that gives you a huge amount of information. It tells you the number of red blood cells, white blood cells, and platelets. It measures the amount of hemoglobin and the hematocrit, the percentage of blood volume occupied by RBCs.
And the CBC also gives us those RBC indices you mentioned earlier, MCV, MCH, MCHC.
Exactly. The red blood cell indices. MCV, mean corpuscular volume, tells you the average size of the red cells. MCH, mean corpuscular hemoglobin, is the average amount of hemoglobin per red cell. And MCHC, mean corpuscular hemoglobin concentration, is the average concentration of hemoglobin within the red cells.
And these are really helpful for figuring out why someone is anemic.
Immensely helpful. For example, if the MCV is low, small cells, and the MCHC is low, pale cells, it strongly suggests something like iron deficiency anemia, because iron is needed to make hemoglobin properly. That case of Mrs. Cretin in the chapter is a good example. If the MCV is high, large cells, it might point towards vitamin B12 or folate deficiency. So the indices help narrow down the cause of anemia right away.
What about the white cells on the CBC?
The CBC gives you the total white blood cell count, but often we need more details, so we order a white cell differential count. This test breaks down the total WBC count into the percentages of each individual type. neutrophils, lymphocytes, monocytes, eosinophils, and basophils.
So that's how you'd spot that shift to the left with the band neutrophils we talked about.
Precisely. The differential tells you if neutrophils are high, or lymphocytes or eosinophils, pointing towards bacterial infection, viral infection, or allergy parasites, respectively. Seeing those band cells specifically listed on the differential confirms that acute bacterial response.
Okay, CBC and differential are key. What other blood tests are common? There was one mentioned for inflammation, ESR.
Ah, yes, the erythrocyte sedimentation rate, or ESR. This is a non-specific test for inflammation somewhere in the body. You basically put anticoagulated blood in a tall, thin tube and measure how far the red blood cells fall in 1 hour. Normally, they fall slowly. But when there's inflammation, certain plasma proteins, especially fibrinogen, increase. These proteins make the red cells stick together in stacks, called rouleau formation, making them heavier and causing them to fall faster.
So a high ESR means inflammation.
Generally, yes. An increased ESR suggests an underlying inflammatory process. It's not specific to what is causing the inflammation, but it's useful for detecting it and sometimes for monitoring the activity of chronic inflammatory diseases like rheumatoid arthritis, lupus, or PMR, polymyalgia rheumatica.
Finally, if the blood test suggests a serious problem with production, you might need to look directly at the bone marrow itself.
Yes, sometimes you need a bone marrow aspiration and biopsy. These are often done together, usually taking a sample from the back of the pelvic bone, posterior iliac crest. The aspiration uses a needle to withdraw a fluid sample of the marrow. This lets you look at the individual cell types, their morphology, how they look, and determine the relative numbers, for example, the ratio of myeloid, WBC precursor cells, to erythroid, RBC precursor cells, which is normally about 3.1.
In the biopsy.
The biopsy uses a slightly larger needle to remove a small core sample of the actual marrow tissue. This is crucial for looking at the overall architecture of the marrow. You can assess the cellularity, the ratio of active marrow cells to fat, look for abnormal infiltration by cancer cells, or detect fibrosis scarring in the marrow.
Is one better than the other?
They provide complementary information. Sometimes, with conditions like acute leukemia where the marrow might be packed solid with abnormal cells, or anaplastic anemia where it might be very empty, dry tap, you might not get a good sample with aspiration alone. The biopsy is often essential in those cases to see the structure and make the diagnosis. #tag outro. So when you step back and look at it all, this whole system, blood, bone marrow, hematopoiesis, it's just fundamental. This constant, tightly regulated process of renewal, starting from those amazing pluripotent stem cells, is absolutely essential for keeping us healthy.
It really highlights that connection between the basic physiology, how the cells are made, what they do, and what we actually see in patients.
Yeah.
Understanding the process helps you understand the diseases and how we diagnose and treat them. And it's worth remembering those age-related points too, like how in older adults, more of that active red marrow gets replaced by yellow fat marrow over time.
Right, which means their ability to ramp up blood cell production in response to stress, like infection or bleeding, is often reduced. They have a less reserve capacity, which contributes to the higher risk of things like anemia or leukopenia in geriatric populations.
And for kids, especially during growth spurts, their high demand for iron to make new red blood cells makes them particularly susceptible to iron deficiency anemia if their diet isn't adequate.
Definitely key considerations in clinical practice.
Okay, as we finish this deep dive, here's something to think about, connecting back to the stem cells and treatment. We talked about using hematopoietic stem cell transplants for marrow failure or leukemia. Now, given what we know about the limited lifespan of mature cells, RBCs last about 120 days, neutrophils may be only hours or days in tissue AO. Why is it absolutely critical to use the pluripotent stem cells for the transplant to repopulate the marrow, rather than just giving the patient, say, a massive transfusion of the mature cells they're missing? Think about that potential for self-renewal and long-term production. We hope exploring your blood's incredible journey today leaves you with plenty to consider. Thanks for joining us.